All right, I'm gonna go ahead and get started here. It's five after.
Perfect.
Um, my name's Ricardo Rendel. I'm one of the second year fellows here at Ryder. I have a case of a brachial gunshot wound with an involving pulse exam. Um, recently we had Dr. Goez come up to Ryder and he did a simulation lab with us on management of vascular injury. So I thought this was a cool case to present, given that he recently came and did a visiting simulation lab with the fellows here at Ryder. So we'll look at some of the operative indications for vascular trauma, approach to some of the repair options, and then look at the AAST guidelines for the management of upper extremity arterial injuries. So here's the case. We have a 42-year-old male that comes to the trauma bay after sustaining a gunshot wound to the right upper extremity and being assaulted. His primary survey is notable for initially, he did not have a palpable right radial pulse. He did have normal cap refill distal to his penetrating wounds. Um, there was inability to obtain a Doppler signal in the radial artery. However, prior to the trauma team leaving the trauma bay, they were able to get a 2+ radial exam. He had no hematoma, no active or no active bleeding or anything like that. His hemodynamics were all normal. He was neurovascularly intact. And the only injuries that he had on exam were the two penetrating wounds to the right brachium. His resuscitation panel here was otherwise unremarkable. His past medical history was significant for schizophrenia. He was actively having auditory hallucinations. He was either lost to follow-up or non-compliant. It was kind of unclear in his history as to why he was not being medicated for this. But other than that, no other major issues. This is the X-ray that we obtained in the resuscitation bay. The paper clips kind of denote where the two penetrating wounds are. And so there, I'll just
Ricardo, would you like to stop there so we can get the panelists to chime in?
yes, sir.
Thank you. So we have Dr. Frisbee. So Dr. Frisbee, give us some wisdom. What would you like to do when you see this patient?
I'll refer him to you. Well, I'd like to know, just out of curiosity, are those two entrance wounds, or is that an entrance and an exit?
It looked like it was an entrance and an exit. He had no retained missile. He stated that he was only shot once.
Well, you better get a road map. See if you can get a CT angio of that arm, or an arteriogram.
Yeah. Well, is there anybody else who would like to act as a panelist? You're welcome. Please go ahead and contribute to this case. Okay, I would like to add a few things to this case.
Yeah.
Well, I know it is well and good to look for the brachial, but at the same time, I think you should get ABI of the upper extremity where the injury has occurred. And you should also document the presence of pulses in the axillary artery and then trace it down to how far you could, because these are very simple things to do with the Doppler machine, non-invasive, and you know exactly what you're looking at. And also, um, did the patient get any prophylactic antibiotic?
Uh, they did not get any prophylactic antibiotics because based off this X-ray, they didn't think that there was any open fracture or anything like that.
Okay.
But
I would have given him a prophylactic antibiotic, something simple like cephalosporin or something like that. And I agree with Dr. Frisbee. He needs to have digital angiogram to see what you can see on the arteriography so that you can plan what you're going to do with this. And also put the timing of the patient's arrival injury time and arrival time somewhere in the marker there, so you know exactly what the time period is involved in the management of this case.
Yeah.
Anybody would like to participate in this case, in discussion? Anything else you want to do?
Yeah, I do. Listen,
Okay.
is the hand distal to the injury? Is the hand cold?
No, warm, well perfused, good capillary refill, neurovascularly intact.
Yeah, get your digital angio.
Yeah. And so I think I wasn't there when the patient came to the trauma bay. I saw him the next morning, but the team that admitted him deferred on getting ABIs because initially he had no pulse, and then he did have a pulse, so they just made the decision to go straight to getting the CTA. And so as you come down on the CTA here, you can see the brachial artery, and then we have a loss of the opacification of contrast. And then distally, we have reconstitution of contrast that goes all the way down with continued opacification. And so the radiology read this as brachial artery discontinuity with distal reconstitution. They were unable to determine if there was injury or external compression, but there was no active extravasation noted. So based off of the CT, any differing management strategies?
Dr. Frisbee, go ahead first.
All right. Well, you're at a point where you either operate or you don't. I like to operate, so I'd open over the injury and proximal to it and distal to it, and get proximal and distal control, and then explore the injury itself. The artery. If I could locate the artery, I would use a Fogarty and clean out all that, which you're going to have a clot, and take it down as distal as you can. And at that point, then you'll have another decision to make as to how to close it. That's
Okay.
all I've got right now.
Well, I would take the patient to the operating room. There is no such thing as conservative management in a case like this, when I know for sure there is a penetrating bullet injury to the upper extremity in the elbow area, and the radiologist says that he cannot see the brachial artery. And so when I take the patient to the operating room, I would prep him and the right extremity plus the left thigh in case I have to harvest a conduit. Again, I would make sure that I get good visibility of everything, and I would do a S-shaped incision in the elbow, and I would go ahead and explore the vessel to see what the penetrating bullet has done, if anything at all, to the brachial artery. I expect to find something for sure. I would be rather surprised if it is just something compressing the brachial artery and we are not able to visualize it on the arteriogram. And that's how I would manage this case for the time being.
Gotcha.
Again, the time factor is very important for me. I would
Yes.
know the time this accident, accident occurred, and what time the patient came to the trauma bay. All these are very important things for me in the management of this case.
Gotcha. So
Anybody else?
no.
We don't have too many regulars who attend this meeting.
I think
So go ahead and go ahead.
the
Go ahead,
ACS
sir.
conference is stealing some of our usual audience, I think.
Oh, I see.
So So the patient was reevaluated and he had a very strong radial pulse. And so the team decided to admit him overnight into the ICU with Q1 hour neurovascular checks. He had soft compartments, normal motor and sensory exam, a very strong 2+ pulse. Looking back at the nursing flow sheet, they were consistently documenting that 2+ equal pulses bilaterally. However, that morning when we came to see him on ICU rounds, he had a diminished right radial pulse compared to the left side. It felt 1+, and the signal was monophasic in both the radial and ulnar artery. At that time, the patient did develop an ulnar claw deformity and had some diminished sensation to the fourth and fifth digits. So we started him on a heparin drip and then got a repeat CTA and arterial duplex. And so this is a 3D reconstruction of the CTA where you can see this large segment injury here to the brachial artery. And then this is the repeat CTA with the runs through. As you can see, the brachial artery loses some opacification, then reconstitutes, and then it goes all the way down. This time the radiologist read it as brachial artery discontinuity with distal reconstitution, suggestive of an occlusion. They had a new finding of a high radial artery takeoff. And then the duplex was very similar. It was reading that there was an occlusion of the brachial artery. And so questions that I had was, I know you guys said you would have taken this patient straight to the OR, but was there any role for any non-operative management in this patient? Was that a reasonable strategy to start off with and see how his exam progressed, or should we have just taken him to the operating room and?
Well, it looks like you did the non-operative management.
Mhm.
And the next morning, we found out.
Yeah.
Looks like he's going to need a jump graft or something to that effect.
Yeah.
That's all I got.
Well, in my opinion, Randall, in a penetrating injury, such as a bullet, when you can demonstrate there is an entry and exit wound by the bullet, and it is in the area of a blood vessel, and the blood vessel is occluded on the angiogram, the first one, I don't think you need any more proof. No matter what you find distally, it is subjective. You're touching the radial artery and you're getting some signal, and you say, "Oh, this is 2+, 1+." It's meaningless, really. Yes, there is a pulse there, but what is the flow in that pulse? It is diminished, or is it? Maybe you're feeling your own pulse as well sometimes in the scheme of things. I think, in my opinion, at least, the way I was taught was that when you see a zebra, it's a zebra. It's not a horse. So get on with it. And
Yeah.
I would have taken the patient to the operating room the same evening that you saw him, instead of waiting till the next morning. Now the time factor becomes very, very important for in the future management of this case.
Yeah.
Okay, go ahead.
So we took him to the operating room. He had a near complete transection of the proximal to mid ulnar artery, and like you said, there was a big clot that we evacuated with the Fogarty embolectomy. The radial artery appeared intact. He got a reverse GSV anastomosis. Looking at the ulnar and median nerves, everything looked normal without any signs of apparent injury.
What about the brachial artery itself?
The brachial artery itself was normal. There was no injury to the brachial artery. The only injury was to right where the ulnar artery took off from it. There was like a 2 centimeter defect once we debrided back. But yeah, he had a big injury there. We did our Fogarty embolectomy proximally and distally and evacuated a lot of thrombus from the ulnar artery. But the brachial artery and the radial artery all appeared normal.
Did you do a Doppler examination intraoperatively of the brachial artery and you got good
Yes,
signals?
we did. There was a multiphasic signal proximally. We had signals in the radial and ulnar artery after we created our anastomosis. His arch was intact. It just seemed to be isolated to that segment of the vessel.
Well, you already told us the patient was getting some claw deformity. Is it like a workman's contracture that you see in neglected arterial injury? But this
No.
patient was already showing some signs of something not being right. Am I correct?
Right. So it didn't seem like the claw-like deformity was from arterial insufficiency. It seemed more like there was some blast effect to the nerve. We looked at the median and ulnar nerves, and they all appeared to be intact. And so actually post-operatively, we discussed with neurology about the ulnar nerve palsy. They had recommended that he undergo an outpatient EMG, but no acute intervention. And by the time he was ready for discharge, the claw defect had resolved, his sensation had improved, and he had full range of motion of all his fingers.
So what exactly did you do in the operating room with reference to where was the arteriotomy? Where did you make the arteriotomy?
So so he had a near complete transection of that ulnar nerve. So we debrided back to
Right?
ulnar artery to healthy ulnar artery, proximally and distally. And then
Right.
because the defect was so large, we did a reverse GSV anastomosis to get a tension-free repair. And so
Okay.
post-operatively, we had him on a heparin drip for 24 hours and then switched him to aspirin. He did get a post-operative duplex that showed everything was widely patent with triphasic signals. We had psychiatry come and evaluate him and help us manage his schizophrenia. And then ultimately, he was discharged to a sheltering home because he was homeless.
I suppose he's lost to follow up.
Yeah, I checked back in the chart to see if he ever came to his follow-up appointment over the last couple of weeks, and there are no clinic notes or no clinic encounters for him coming back. So he's unfortunately been lost to follow-up. So one of the questions that I had, for patients like this, when you're trying to do post-op surveillance of them, any strategies or anything that you guys would recommend, but it helps when they show up to a clinic.
What was the time period from the time he was seen in trauma bay by the time you got the patient to the operating room?
Uh, He came in the middle of the night before my call shift, I think around like 10 p.m. or 11 p.m. or so, and then we took him to the operating room that morning.
So it's over 6 hours,
That's
right?
Yeah,
it's over 6 hours, right?
yeah,
You're a lucky man.
Yeah.
yeah.
Did you do any compartment pressure management?
We didn't check compartment pressures. His forearm compartment felt completely soft. And so, we didn't think that he had any evidence of compartment syndrome or anything like that. He stayed in the ICU for 2 days for, Q1 hour checks, and his compartments were completely soft with serial checks or anything like that. We didn't do any prophylactic fasciotomy.
Lucky. Did you harvest the vein from the upper extremity or lower extremity opposite side?
Lower extremity opposite side.
There was no size disparity, right?
No size disparity. Everything kind of just laid perfectly for us in terms of creating the anastomosis.
Well, somebody's looking right. Good.
So looking back at this case, what are the pearls you would like to tell us?
Yes. So looking back at this case, I agree with you, Dr. Kasim, and Dr. Frisbee. You know, when this patient initially showed up and had a pulseless extremity, I would have taken him to the operating room. The fact that he got a pulse back, I think it was appropriate to get the CTA just to get a roadmap, like you said, of what could potentially be going on. But I agree, early exploration of this to exclude an injury if radiology is unable to definitively tell you, I think would have been appropriate management for him.
I agree.
And then, so I have some slides, some educational slides here. These are from the AAST guidelines. I think 2021 they published this. Their injury grading scale, this patient would have had a grade 3 injury. But like we discussed, hard signs warrant surgical exploration. Any hemodynamically unstable patient with soft signs also warrants exploration. Like Dr. Kasim said, even though you have a presence of a peripheral pulse alone, that cannot reliably exclude any injury. So if there's any mechanism that's concerning, like a penetrating injury, you should have a high index of suspicion for these things. Like we talked about, ABI can be effective for screening for arterial injuries, but you don't necessarily get any information on the venous side with ABI. And even patients with normal physical exam, normal ABI, these patients can be discharged, but they do need outpatient follow-up due to the risk of getting a delayed pseudoaneurysm. Um, Isolated injuries to the ulnar radial arteries with an intact palmar arch with occlusion can be ligated, and there's low rates associated with digital ischemia. We did discuss this in the operating room, given that the patient had intact palmar arch and signals with the ulnar injury clamped proximally and distally. But because he wasn't in any hemodynamic extremis or anything like that, we felt that it was appropriate to continue with revascularizing that. This just looks at how brachial injuries have high morbidity. They account for 23% of our extremity vascular injuries. Because the brachial artery has a high profunda brachii branch, patients can get collateralization around the elbow, and they can still continue to have flow past an injury in relation to where the injury would be if it was proximal or distal to the profunda brachii. Like we said, short segment injuries can be managed with end-to-end anastomosis. Small defects can be managed primarily. Large defects will require interposition grafting with either autologous vein or PTFE. In hemodynamically unstable patients, using temporary shunts is appropriate management, and then ligation should only be reserved for life-threatening situations. And there are commonly nervous injuries related to these injuries. And then this last one is just more kind of my own interest. Where I did residency, we always called vascular for our vascular trauma, but here at Ryder, a good number of the trauma surgeons feel comfortable managing vascular trauma. This paper looked at outcomes in extremity vascular trauma and which service does the repairs between trauma and and the vascular service. They saw that the trauma surgeons were more likely to manage upper extremity or proximal lower extremity injuries and isolated injuries. Trauma surgeons were more likely to perform primary repairs. No difference in the rate of autologous vein or synthetic graft repairs between the two services. And then the complications that they had listed there, they had no statistical significant difference between the two services in terms of management and post-op complication rates. So I thought that was pretty interesting that the trauma surgeons were able to demonstrate a similar complication rate to vascular service. I don't know if that's similar for you guys, Dr. Kasim and Dr. Frisbee. Is trauma doing the majority of these repairs at your institutions? Is it 50-50 or is vascular always called regardless? I think you're muted, Dr. Frisbee.
Well, that
And Grady likes to be the one to do the case, unless they get a something that's over their heads, and you'll never get them to admit it. But most of the time, it's the trauma people who do it.
well, I'm a trained vascular surgeon, so I usually don't call anybody. I deal it with myself. And of course, if I am stuck with difficult cases, it's always a good idea to get a second opinion from a colleague.
Gotcha. Another question that I had was, on vascular, whenever the patients are undergoing these kind of procedures, they get heparin boluses and ACT monitoring. There was a few papers that said that trauma surgeons don't really do all of that. Have you guys noticed that there was a difference in terms of that kind of management with the intraoperative anticoagulation?
I think postoperative or intraoperative postoperative management of patient, as far as the anticoagulation is concerned, it is very much operator dependent. Some people do that, others don't. And I was taught to be cautious, so I try to do that as often as I can. And sometimes I forget till somebody reminds me postoperatively. But I think it's a good idea because it is a preventive measures. Unless there is an overwhelming contraindication to patient getting anticoagulation.
Awesome. Well, that's all I have. Thank you guys so much for your time and your expertise.
Well, there was a short morning,
That
but
was a
very
good
good
one.
case.
Actually, that
Good
was
one.
good. Short and sweet. I like this. Come back again.
Yeah. Randall, Dr. Randel, you don't look Italian, but it was a very good presentation, very good analysis, and citation of your papers are all very, it's a good one. And we thank you for presenting the case and educating us.
Thank you.
Thank you, Dr. Rendel, and thank you, Dr. Kasim, for moderating.
See you next week.
All right. Take care.
See you next week. Take it easy.